Welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins surgical oncologist and medical oncologist, Doctors John Migaly and Nilo Azad, will be speaking on rising rates in early detection, understanding early onset colorectal cancer. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenters. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note, if you do not want your name attached to your question, please check send anonymously. We will do our best to answer all the questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Drs. John Migaly and Nilo Azad to begin our presentation.
Well, good afternoon. Just wanted to do some introductions. I'm John Migaly. I am a colorectal surgeon by trade. I am the chief of the Division of Colon and Rectal Surgery at Johns Hopkins Medicine, which includes Johns Hopkins and the 4 Hopkins hospitals. This is a project that's near and dear to my heart, and these patients have become an integral part of our everyday life in the cancer center. We are happy to be able to transfer information to the people on this Zoom. I think this is something that will be one of our biggest concerns in the cancer world quite quickly. And I'm going to turn it over to Nilo for introductions, who's I am really pleased that I have gotten to work with Nilo since I've gotten to Hopkins, and we've really partnered in a lot of these really important events. And I think she is a world's expert on this, and you should. I think you'll really enjoy her thoughts on where we're going with this really important problem we have.
Well, thank you. That is such a kind introduction. I want to thank all of you for joining us, on a 5 o'clock on a Thursday to talk about, I think, something that John and I really feel is one of the biggest problems that's confronting us in the colorectal cancer community right now as doctors that take care of patients and as researchers that are trying to understand what's happening in the colorectal cancer world. More and more we are seeing our clinics fill with patients that are just far too young to be diagnosed with this cancer. And so, hopefully this afternoon we'll be able to spend a little bit of time really talking about what we're seeing, and maybe more importantly, what we can do both to try to stop this cancer hitting our young population in terms of diagnosing it earlier, keeping a high amount of vigilance when people are having symptoms, even if they're young. And then, a lot of the research that's ongoing and how we're trying to really frame our clinical care around the special needs of this particular population. So I really appreciate being invited to be a part of this. And I think we have a few slides we wanted to share with you. We really are hoping for this to be pretty interactive. And so John and I are going to try to be really interactive about it. And we're really looking forward to you guys peppering us with as many questions as you can around this as well. And so this is a series of graphs that are just talking about the incidence of colorectal cancer. So how much colorectal cancer are we seeing in this country over time? And just to kind of frame what you're seeing here on the top, what you're seeing is the youngest people with colorectal cancer. And you can see that that curve, that line is really heading upward. So in young patients, we're seeing more and more colorectal cancer. It's not just a sense of who we're seeing in our clinic, but the national numbers are speaking to this, dramatic rise, especially look at that 20 to 29 year in terms of the scale. I do want to say that, and I just am saying this is a seminar about young onset colorectal cancer, but this is still a cancer of people that are older overall, right? So if you look at the y-axis, that part on the left of the graph, the numbers are still pretty small, but that actually creates a problem because the numbers are so small that a lot of times there's not that vigilance, especially when someone's starting to have symptoms, even though we're seeing more of it. People aren't thinking that this is what's happening. And so that's, I think, I see that a lot, John. I don't know how you feel about when people come in and say that they've been having symptoms for months and months, and, someone just told them that, hey, it's hemorrhoids.
Yeah, I mean, I think that's the most common thing I hear from the younger patients is, there's some sense of, either hopefulness or maybe disbelief when when they present to their docs and saying, I'm having a fair amount of rectal bleeding. It's been going on for months, and almost, all the time when they present late, it's been going on. They told me it's hemorrhoids, and it ends up not. And I think I'll tell you, I've been in practice for 20 years, and it was uncommon to see people under 50 with colon and rectal cancers. And now, I mean, obviously, we're seeing a different set of patients at Johns Hopkins than we do everywhere else, but it's about 50% of what I'm seeing. That's not the incidence in society, but that's what we're seeing here. So it is definitely something that sometimes the patients almost need to advocate for themselves to get themselves to a colonoscopy.
Yeah.
I think if you look at this slide, I think Nilo kind of alluded to this. If you look at the 40 to 49 group, that's a steady increase. But if you look all the way towards the 20 to 29 group, that group is going up by almost like 5% per year. And as opposed to the 40 to 49 group, which is like 1 to 2% per year. And that's just really impressive by any sort of measure. If you look at the other graphs, actually the incidence of cancer in the older groups is either held steady or gone down. So while Nilo said that this is still uncommon, I think there's data to suggest that by 2030, 11% of the colon cancers and 23% of the rectal cancers will be people under 50. So it's pretty sobering.
Dramatic. Yeah.
So if you look at not only the incidence, but look at the mortality. If you look at the 0 to 49 group, that mortality has been slowly increasing over the years, as opposed to the 50 plus, where the mortality is actually improving over time. So part of the take-home message to this is that the patients are being diagnosed at a much later stage, and therefore survivorship is being affected.
Absolutely.
And I think that that's something really important. I think the other thing to understand is that all of these graphs, they put colon cancer and rectal cancer together. And actually, when you separate them out, the data for rectal cancer is even worse in terms of survivorship and people that present with disseminated disease. So I think that in my practice, and actually when we looked at our data for the center, and Hopkins is part of the Committee on Cancer, and we keep something that is called the National Cancer Database. And this is a joint effort between the Committee on Cancer and the American College of Surgeons. And it is a prospective database that actually runs across a fairly large majority of hospitals in the United States and captures about 77% of all cancer diagnoses. So when we look at just the Hopkins data, 50% of our rectal cancer patients that have spread or metastasis, 50% of them are under age 50. So granted, we're seeing a very
Select population, you know.
select population and skewed population.
Now, we are very lucky to practice in a very diverse area here in Baltimore. But I think that it's important for us to know that that diversity does also have its own nuances when it comes to colorectal cancer as well. And so we are also seeing an increase of incidences in younger Black patients compared to white patients. And, you know, that is also something that has many pieces to it. There may be, you know, a biological difference, but there may also be a difference in access to earlier screening and care, because you can, you know, colorectal cancer is one of the cancers that's very preventable because you can find it at a pre-cancerous stage, right? If you get your colonoscopy on time, then you can find colorectal cancer when it's still precancerous. And now we're allowed to start screening people at the age of 45 by national guidelines. So I think it's a really important thing to make sure that we're socializing and educating our communities about is that at 45, we should start getting colonoscopies in the average risk patient. And that's not people who have a family history. That's just the average risk patient.
So what drives the development of colon cancer in young patients? If you look at, I mean, the development of colorectal cancer is associated with specific mutations, and it's basically how a polyp eventually becomes a cancer. But if you look at the actual mutations in the genes, if you look at the over and under 50-year-old population, there's similar frequencies of this group of mutations, the P53, APC, BRAF. We're not going to get too far into the weeds about this. However, in the younger patients, there is higher rates of mutations that are associated with inherited colorectal cancer syndromes. And it doesn't necessarily mean that you have an inherited colorectal cancer, but you have mutations associated with it. So that is something that's really interesting in terms of how you offer therapy and what kind of therapy you can immunologic therapy versus traditional chemotherapy, and how you can essentially personalize the therapy to each patient. It also starts to really make hints at our interactions with the environment.
Yeah. I think, you know, one of the questions that I feel like I'm asked the most when patients come in to see me is, why did this happen? And how can we make sure this doesn't happen for our loved ones? And I think the challenge is that while there are all of these different pieces that we can look at and say, look what's been changing in the last 30 years for Americans, that has, you know, we know that Americans have there's an obesity epidemic. We've got more Americans that are diagnosed with diabetes. Our food has become hyper-processed. There are associations when you try to look in the laboratory about those things making cells more likely to turn into cancer, but you can't really nail it down and say, if I make this change, I can avoid getting colorectal cancer. So the truth of the answer when people ask that question is that we don't know which of these things matters most, how many of them, and many people who come in with this entity, have no risk factors. It just ended up being bad luck for that person. So, but we do think that, there are key things around maintaining health when it comes to weight and sugar metabolism that is important.
Yeah, I think like on a population basis, you could say, well, there's certain things that you can't modify. You can't modify male versus female or kind of the genetics that you were absolutely born with. But there is an association with the Western diet. And I always tell the patients, the standard American diet, is now pervasive around the world. And
Yeah.
so this trend is happening in Europe, in East Asia. And I think it's because of the pervasiveness of the standard American diet. And I always tell people, remember the standard American diet, the acronym is SAD. So it's a lot like Nilo said,
That is true.
yes, it's a ton of, just think about how like a piece of bread now versus in the 1950s, how much processed sugar is in it. And we think that there is a association with hypercarbic diets, insulin levels, unopposed insulin growth factor. There's also an association with physical inactivity. Obesity causes a pro-inflammatory state, and once again, diabetes and insulin-like growth factors, smoking and alcohol. And then there's a lot of typical questions that we get asked about, smoking, as we said, excess body weight, excess red meat, processed meats, low dietary fiber, low dietary calcium. So they're sort of potentially modifiable risk factors. But if we can say there's, A leads to B leads to C, we'd probably be kind of making things up. But these are on a population basis. I think these are things that if we could modify, we probably should.
Yeah.
Yeah.
So
So
when Go ahead. So, when we think about a person who's been diagnosed with colorectal cancer, there are some pretty standard steps that anybody can expect. And the initial diagnosis of this cancer is done on colonoscopy. So it's a direct inspection of the colon and a biopsy that's done. It's looked at under the microscope, and that's what proves that someone has colorectal cancer. Now, every patient that has colorectal testing will undergo something called MMR or mismatch repair testing. And what that means, and it's especially important for anyone who has rectal cancer, is it's a test that's looking for a particular genetic abnormality that's present in young people with rectal cancer, about 5 to 10% of patients. And if patients have that abnormality, they might be able to actually be treated if they have rectal cancer with just immune therapy and not have to undergo surgery. And so it's a pretty amazing situation if you end up having to be diagnosed with, or a person is diagnosed with this cancer. So that's an important thing that every rectal cancer patient should have. And then, of course, there's the rest of it where you get staged to make sure with a chest, abdomen, pelvis scan, you get blood work, and that is to give us a sense of what the stages of the cancer. And then we move into the surgical part, which I'll let John speak to, since that's your bailiwick.
So I think that you have to fit the surgery to the patient. Now, there are familial or inherited colorectal cancer syndromes where it makes a lot of sense to remove the entire colon. Unfortunately, these represent less than 2% of all the colon cancers. I think that when we talk about colon cancers versus rectal, our goal is to do a curative cancer operation but to preserve function as much as we can. So when we kind of differentiate colon from rectal, with with rectal cancer, totally different game than colon. The rectum is in like sort of sits in your pelvis, very difficult area to operate, very important high real estate area. You have prostate or bladder or vagina or blood vessels that go down to your legs, nerves of sexual function, things like that. So as much as we can, we try to, one, shrink tumors as much as we can, and two, if we do need to remove the rectum, we want to, as much as possible, preserve the organ. Now, there is more and more data for rectal cancer that says that many of these patients may not need an operation. We'll get to that. We're getting a little ahead of ourselves. But in general, we want to do curative operations when we have to operate. And that in general, we want to preserve function as much as possible. That's why we work hand in hand, almost on a hourly basis, with our medical and radiation oncologists, and especially at a place like Hopkins, where we are unraveling some of the treatments that are really doing wonders for our patients. And as Nilo said before, that it would have been unheard of to actually not operate on rectal cancers 15 years ago, and now we have an entire protocol around that. So I think we've made some good progress. I'm gonna ask you a question after you're done with this slide that I'm gonna be interested in your answer.
Yeah, so after the surgery is complete, if a patient has a little bit higher stage disease, they might need some chemotherapy. So then they send them over to medical oncology. That's really if the lymph nodes are involved. Or now we're starting to do a test where we test people's blood and we look to see, are there any signs that the cancer might have gotten free a little bit? And so even though after the surgery, we might still be able to detect little pieces of the tumor DNA. And if people have that, then we might consider doing chemotherapy as well. And then after that, this is actually a highly curable cancer if it's caught early. And so we're really, the majority of our patients, if we catch it before it's stage 4 disease, we're really able to move into surveillance and follow people for many years with scans and blood work, and they get scopes as well. And then, we hopefully give them a clean bill of health after a few years. Unfortunately, that's not everyone. So were you going to ask something about this, John, or?
Well, two things, there is a lack of guidelines for younger patients. And I think a lot of people, say, when we have older patients, we say, okay, 5 years, and we sort of, kind of pull back with imaging and things like that. But a lot of people are saying there should be no endpoint for surveillance for young patients, like after they've had treatment. What do you think about that?
Yeah, I don't know that I agree with that. For a few reasons. I mean, the reason that we end surveillance even in older patients at 5 years is because if you look at the recurrence risk, it just drops off dramatically. And so it really drops off significantly after a couple of years. And then after 5 years, it really drops down to like low single digits. And so if you're young and, if you're 40, 50, and then we're buying people years, decades of radiation exposure from CT scans. So I just want to indicate CT scan radiation exposure is quite low now. But, so I think that there is a time where you get to just be a cancer survivor. And until there's any data that supports that there would be some benefit to that, or that people's late recurrence is higher in younger patients, I haven't seen that data. So that's just my 2 cents on it.
Yeah, well, the lack of data kind of drives sort of like the paucity of recommendations,
Yeah.
so
Yeah.
and then I often have patients ask me about a colonoscopy versus a Cologuard. Do you want to talk about that a little bit?
Yes. So we are lucky that there are different options for doing screening at that age of 45. And so a colonoscopy is the gold standard because someone's going to be looking in the colon, and if there are any polyps, the precancers are actually removing them. So that's actually therapeutic. You're able to pull something out, and stop someone from ever getting a cancer. But there are tests that are being done that are stool tests. So basically, you can just take a small stool sample and mail it in, put it on a card and mail it in, and it's detecting both blood and or some abnormal DNA that the cancer makes, and they're very sensitive. And so it is an excellent test as well. It just doesn't have the therapeutic part that a colonoscopy has. And so my general recommendation, of course, I'm already seeing cancer patients, so I'm skewing towards the colonoscopy anyway. But in my family, for myself, for my my loved ones, I prefer colonoscopy. But if someone is not going to do it, or you can't get in, sometimes it's hard to, depending on what area people live in, sometimes it's even hard to get on the schedule for colonoscopy. Then doing Cologuard testing is also a very strong and reasonable thing to do for screening. How do you feel about it?
I would prefer for me or my family members to get a true colonoscopy. And I also want to remind people on this call, or maybe just tell them, that Cologuard testing is only for people that are average risk for colon cancer, meaning they have they don't have a syndrome, familial syndrome. They have no relatives with colon cancer, no first-degree relatives, either sibling, father, mother, or child with colon cancer. So if you're average risk, meaning no family history of colorectal cancer, no syndrome, or you don't have anything like inflammatory bowel disease, those are the people that are appropriate for Cologuard. I will add that there is a sort of a miss rate for colon cancer or cancerous colon polyps for Cologuard. It's about 8%. And actually can miss over 40% of precancerous polyps, which is back to what Nilo was saying, is that some of these polyps aren't cancer, but they still need to be removed, because if you leave them long enough, you're sort of rolling the dice. They also have a pretty, I think about 10%, 10 to 13% false positive rate, meaning it'll say there's something wrong. You'll get your colonoscopy and they won't find anything. So
Yeah.
You want to talk a little about the chemotherapy?
Yeah. So the next couple of slides, are really just to give some flavor about the kinds of treatments that are possible for patients that are diagnosed with colorectal cancer, usually at stage 2 or further. And so rectal cancer in particular needs many different kinds of doctors to help treat it, to keep it from coming back. So rectal cancer is often treated with chemotherapy and radiation. Often we do that prior to surgery. And then I did mention that patients that have that genetic abnormality might be able to get immunotherapy. And so that whole process, you can see that at the bottom, that whole process takes 6 to 9 months while you get through the chemotherapy, the radiation therapy, and then go to surgery and then have the reversal. And then the next slide is really focusing on metastatic cancer. And that is just really for patients who are diagnosed with metastatic cancer to know that there are so many differences and options compared to what we even had a few years ago. The survival for metastatic colorectal cancer is in the multiple years. So it is a highly treatable cancer. And even, with our patients who are a little bit younger, even a handful of years isn't enough. And so we're doing a lot of work on clinical trials. There's been some really exciting data that's been coming out in the last 1 to 2 years around cancer vaccines and targeted therapies. And then there's these other kinds of therapies that can target different organs, especially the liver. So this is just really to give a flavor of the fact that there are many options. And these are things that a major center like Hopkins can really provide. So I think that can be an advantage of being at a place that has a lot of subspecialty expertise, is that you are generally being able to be treated both aggressively and a little outside of the box with the newest technologies. And maybe John can speak to that a little bit.
Yeah, if you kind of look at the data of under 50 versus over 50, they do get treated a lot more aggressively. They tend to get more chemotherapy and more types of chemotherapy. They get more organ-directed therapies, surgical therapies. So what are things that we do at Hopkins besides, like surgical resections, removing the tumor? We have hepatic artery infusion pumps where you can put a catheter directly into a blood vessel that goes to the liver, and then there's a little reservoir under your skin, and they load that up with chemotherapy, and that chemotherapy gets directed to the liver to increase the amount of chemotherapy that can go to the liver and to decrease the rest of the toxicity to the rest of the body. Our liver surgeons are some of the best in the world. There are also therapies like radioablation of liver lesions. And honestly, there is a lot of data coming out that when patients that have stable yet unresectable, like it's not like technically possible to remove those portions of the liver with the cancer in them, if they have stable disease, they can be transplanted. And then for people that have intraperitoneal disease, peritoneal implants, which are essentially, it's a fancy word for saying like pock marks or buckshots of like tumor all over the inside lining of the belly. There is, we have a very aggressive peritoneal disease program here where we could strip those pock marks off of the abdominal wall and give heated intraperitoneal chemotherapy. And so I will tell you that, not only do we do, straightforward, straightforward resections, but we do combination resections, and we do, sometimes we have 3 different surgeons in the rooms of various different specialties. So we do everything from the garden variety to the advanced, because the data is evolving, and we have survival strategies.
Yeah.
So here's a real important conversation.
Yeah.
Yeah.
So when we've got folks that are still in their childbearing years, we really want to be paying attention to fertility. And so this is a question that comes up a lot, and a lot of this has to go into planning how you're going to treat a patient, and you got to do it relatively quickly. So you have to have all the different pieces in place that can really help do these things so that you're not delaying therapy for patients, but you're still making sure that you can do everything that you can to protect people's fertility and eventual sexual function. So for women, when you think about radiation, which we talked about being a necessary part of a lot of rectal cancer, it's about how do we keep the ovaries from being radiated if possible, so that you still have ovarian function, which is both important for fertility and for sexual function. And then also, what about the uterus, right? So the uterus, if the uterus is radiated, that's also, that can be an issue as well. And we'll talk about some radiation sparing approaches in a couple of slides, but we want to do everything that we can. And any woman who is diagnosed with rectal cancer, these things need to be dealt with very quickly and as part of the early part of their diagnostic and treatment plan. And the next slide is about male fertility. Maybe you can take this one, not to be sexist that I took the women and you took the men, but.
So first of all, for men, same sort of urgency around this, because a lot of times they're going to receive irradiation to their pelvis. And so, in our young patients, they are going to want to think about reproduction and to bank sperm And honestly, I'm going to tell you that organ-sparing procedures they do almost inevitably involve irradiation. So you're kind of sometimes, you know, saying, well, I get to keep, I get to keep my organ, I get to keep my rectum, but the price I pay is irradiation versus, an operation. And the operations, they result you know, in the pelvis, there's nerves of sexual function, and these nerves of sexual function can be affected by radiation, and they could be affected by the operation itself. So obviously, you want to be at a place where people understand rectal cancer and operate it on it, as their sort of their reason for being. And it's really important to be thoughtful about one, we need to thank sperm. Number two, if we're going to do a procedure where we're going to remove the rectum, this needs to be a skilled surgeon who can identify the nerves, who more likely than not will use a robot, who thinks, who has done this so many times that they understand the operations. And so I think that's part of, preserving function.
Yeah.
And
And I think what we as a field have realized, and over the last 10 years, is that when you've got three different parts of treating rectal cancer, chemotherapy, radiation therapy, and surgery, each one of those come with their own long-term side effects, right? And so the community has really gotten together, the research community, and it has done multiple clinical trials trying to see what's possible in terms of minimizing those approaches so that people can survive their cancer at the same rate, but they will have less long-term side effects because they are avoiding something. And so these are studies that have looked at the idea of giving some chemotherapy, but maybe not giving as much chemotherapy to patients. The next slide is showing a similar approach with radiation. So a very important trial that was done looking at whether you could take some patients and give them radiation and other patients avoid the radiation, and would patients turn out the same? And in the right patients, if you select the right patients, there are actually patients that can avoid radiation, and radiation does have significant long-term side effects that we were just talking about. And so this trial, which was called the Prospect trial, says for certain patients that have stage 2 or stage 3 rectal cancer, but very particular patients of this group could actually avoid radiation. And then similarly, a different series of trials, we're looking at what about surgery? What if you give radiation and chemo? And can some patients just be followed afterwards if they have a complete response and all the cancer looks like it's disappeared? Now, John, this is not something that's without risk, so maybe you may want to speak to that, right?
so this is called watch and wait. So I'll be very careful about talking about this because I don't want to make patients or family members of patients or friends of patients saying that this is something that we could bluntly apply to every type of rectal cancer. So there is great data to show that if we give full dose chemo, full dose radiation before we ever do surgery, that about 35, some people even say more, 40%, when you look in their rectum afterwards, they won't have tumor. When you do an MRI, they won't see anything that looks like tumor. And so about 2 decades ago, this actually started in Brazil. People started sort of experimenting with something called watch and wait. It's like, what happens? What's the natural history of this? Um, and a certain number of patients can be watched and may never need surgery. We do know that maybe 20 to 25% of them will recur, but that leaves another. So it's a subgroup of a subgroup. 35% will get a complete response, and a quarter of those people will recur, but they need very intense follow-up MRIs, exams every 4 months. So treating younger patients, super important. This is something we have to think about all the time. We want to talk about, the effects on fertility, sexual health. There are financial implications. These are people that are out there working, don't have disposable income, have, sort of, um, real life sort of day-to-day, young kids, childcare issues.
Yeah, I mean,
Those-
you imagine, right? You're in your 40s or 50s, and if you're like me, you've got parents that are elderly that you're caring for, that have a million different doctor's appointments you're trying to get them to, and you have your kids that you're trying to drive to all their different activities, and you've got your work, which you're also supposed to be gainfully employed to be able to support that family, and so it's just that prime busiest time of people's lives, and then they get hit with this out of nowhere, right? And so it just has a lot of challenges when it comes to being able to navigate all the other things in life that make life life, you know?
and I think you need, I honestly believe that you need to be surrounded with I think you need to be wrapped around, but the people that are going to treat you need to wrap you around their resources. They need to pull you in, and you need a navigator, to help you through all this mess of appointments. You might need a financial counselor. You need to talk about genetics for your children or your parents. You want to do egg harvesting or ovarian transposition or sperm banking. You need to talk to somebody who's had who's had this before or has had a colostomy before. I mean, I think these are things that I think that when younger patients are out there trying to do this, when you don't have the sort of that wraparound of like what the institution can supply, I think that's pretty daunting. Think about just the cost of fertility treatments, or sperm banking. These are real issues. And the financial cost of colorectal care. It's pretty daunting.
Yeah. Yeah.
Yeah.
I mean, this is like the average salary for for a family, right? And so to be able to when you look at these numbers, it's just sometimes seems unbearable for a family to be able to take this. And in fact, a cancer diagnosis is one of the leading causes of financial insecurity for people in this country. And so I think, and colorectal cancer is actually close to the top of that. And so it's a very it is a very meaningful thing that we know has significant impact. And places like Hopkins really focus on having significant social work support and to really kind of help with some of that kinds of planning,
Um, so, the young early onset young colorectal cancer programs in the country, they're few and far between. They have some common themes that we have just talked about. And I just, keep those in mind. I'm going to say one thing is that in addition to that wraparound care, it's about, contemporary and out of the box treatment. It's also about like informing the treatment of other patients, meaning that, and I know that when people are stricken with cancer, the last thing they're thinking about is like, what about the next person? But you have to go to a place where they're collecting data and they're doing deep demographics and they're taking tissue samples, because in isolation, in a small hospital, even in a university hospital that doesn't have its act together, there's even in each patient, there's information locked in there that's going to help another patient. And that's why you need to sort of, think about these things so that when you go to a place that is collecting that information, because it's going to help somebody else too.
Yeah.
Do you want to talk a little bit about the program?
Yeah, so we have been well aware of this challenge as we've been taking care of patients, and so we've started an early onset colorectal cancer program here, and this is really around making sure that we are on top of and that patients are feeling empowered to understand what they're going to need and what we can help them with. And so that's a two-way conversation, right? At the beginning of a diagnosis. So when a patient first comes in, not only do we need to do all the medical pieces, that's what that first billet is, but we really want to assess all the other components that are necessary as well. And then, as I mentioned before, the fertility preservation piece has to happen at that very beginning piece. And then the next step that happens basically concurrently is a multidisciplinary clinic that really John leads. So maybe he could speak to that.
Well, I think really what it is taking an approach that, number one, individualizes, but also individualizes the care to each patient, but also takes into account that we have vast resources that the patients don't know, and we need to activate them. So a lot of it is, it starts once again, with the gathering of the information, but then it's coordination between the specialists and understanding that the decisions are made, in a group setting so that there's multiple eyes on the patient. And then assessment for clinical trials, because a lot of the no patient fits, perfectly into one set of criteria or another. Understanding, how to integrate them into the other things that we offer, such as the rehab medicine, the integrative medicine, the fertility, the buddy programs, and then longitudinal follow-up. These are very important things. And so I think when I say it's important to go to a place that has these facilities and resources, I do think that there is some security in the overlap of the number of people that are sort of taking care of you. Does that make
Absolutely.
sense? Yeah. Honestly, this has been a pleasure talking to the listeners here and the people on this Zoom. I'm very passionate about this because I think this is, in each decade to decade and a half, there is an overwhelming cancer problem, and it was prostate at one point, and then it was breast, and then honestly, like there's what we know about those two cancers and the survivability has grown by leaps and bounds, and this is a humongous problem, and the more we can let people know about this, the more they can be proactive. Nilo?
Yeah, absolutely. I want to think, we see each other all the time when we talk about our patients, but it's kind of nice to be able to sit here and talk through, how we really feel about taking care of people. And I want to thank all of you guys. We're going to spend a little bit of time of answering questions right now too. But these are the phone numbers for if anyone needs any help in taking care of colorectal cancer. If you've got if yourself, friends and family, of course, we hope you don't ever need these, and that you're just here to get a little bit of an education on this, but we're always here for our community. So there is a question in the chat about why is it that incidence is decreasing in the elderly population, and is there something that we could be doing so that could happen in the younger population too?
So I think there's probably two reasons for this that come to mind immediately, but maybe Nilo will have something to add. I think that it's the data shows that the stage on presentation that younger people present with is higher, meaning more advanced, and therefore that's survivability. But why is the incidence? And I think it has a lot to do with the environmental factors that people are being exposed to earlier in their lives. So, and then number two, I think that creates a different genetic milieu for those patients. What do you think, Nilo?
Yeah, I think that's absolutely right. I think, we're doing better with screening, but we're also we're seeing that many things are changing health-wise in our population based on age. And I this is another one of those things where we said we're not exactly sure why things are happening in terms of increasing in the older population, but the screening numbers and being able to diagnose things earlier really do give you a good sense of how you might be able to catch things earlier. And that actually speaks to another of the questions about do we think that insurance companies might lower the colonoscopy requirement from 45. So, in the United States, the way that this works is that there are guideline committees that are made up of, the biggest one is the U.S. Preventative Task Force, but there are multiple guideline committees that look at the data and they look at the numbers and they look at the cost benefit analysis of doing colonoscopy. So if you then started doing colonoscopies in everyone over 40, that extra 40 to 45, how many people would you catch early? And how many lives would that save? Versus how many people might get hurt by getting colonoscopies. Because even though it's a very small percentage of chance that you could have a complication, how many people might you have complications for? Are there enough cancer cases in that patient population that it's worth that risk and then worth the national cost financially? And when those recommendations are made, insurance companies kind of have to follow them. And so so the analysis is done by, I would say, objective mathematical and health researchers, and then the insurance company follows. But on their own, insurance companies will never do anything new, in my opinion. It's about kind of that national task force, and that's why it's so important that we fund these registries. So the cancer registries have been big thing on the chopping block right now in all these conversations about what the government should or shouldn't pay for. But these national registries, that's how we find out what cancer incidence is, and that's how we are able to make plans and make recommendations. And if those numbers don't exist, we won't be able to do that. And so I think, the more that you all can do to advocate for making sure that we know what is happening at a health level for our population, the better that your doctors can take care of you.
There's a question about Cologuard and which we talked about, but our thoughts on virtual colonoscopy. I'll just say I occasionally use virtual colonoscopy for patients that they have obstructing tumors where we can't look at the entire colon. We know that there might be as high as a 2% chance that they'd have a synchronous cancer, meaning a cancer somewhere else in the colon, so we need to see the rest of the colon. And probably about a 20% or more chance that they would have a polyp somewhere else in the colon, which we should probably remove. So it's virtual colonoscopy is not as easy as you think. It still requires a prep. It still requires, for you to get a large amount of fluid put into your backside to visualize the colon. So it's not exactly comfortable for the patient. And unlike colonoscopy, there is no sedation for it. And it does not allow you to address any abnormalities that you'd find. So I think it's probably become essentially third line.
Yeah.
Symptoms. The symptoms can be vague. So first and foremost, it's going to, the one that everyone sort of brushes off is the bleeding. And, whether it's a little or a lot or episodic bleeding, I think bleeding that is, repetitive, even if it's a small amount, should be addressed aggressively. And I mean that because most of the patients will tell you, I had a little bleeding, not a whole lot. And then a couple months later, things kind of spin out of control. Weight loss, these are vague symptoms. That's why people say that, colon cancer can be a silent killer, because the symptoms are vague. Weight loss, some abdominal pain, change in bowel habits, sometimes more diarrhea, sometimes more constipation, sometimes you're constipated and you go to diarrhea. So, I'm highly alerted to these when I see patients in the office. It's just hard to, once again, you have to kind of advocate for yourself, because there can be a dozen other things that cause these symptoms. I left the ivermectin question for you.
Yeah, I mean, ivermectin and mebendazole are great antiparasitic drugs. And so they absolutely have a role in taking care of people who have parasitic infections, but they don't have any anti-cancer benefit, and that's been studied. I know there's been a lot of enthusiasm. I get asked about ivermectin a fair amount, but it has not it has not panned out as something that has been helpful. There is a different question about KRAS G12D inhibitors. Yeah, you're speaking my language. I'm a big KRAS targeting person, and that's a huge area of my research. KRAS inhibitors, especially G12D inhibitors, are looking more and more exciting in the clinic. These drugs are not FDA approved yet, but there are literally dozen now that are in the clinic being tested. We run many clinical trials. I personally, that's what I do. So I have, I think 7 trials that are open right now for KRAS mutations. And so it absolutely, right now those trials are generally being tested almost exclusively in the metastatic setting. But if someone has a KRAS mutation, G12D is one mutation, it's the most common. And we have many studies that are specifically for that, but we actually also have clinical trials that are open for people who have other KRAS mutations. And so it is absolutely something worth reaching out to us about. And there are some other centers that work in this space too. But yeah, very exciting area.
Other environmental factors, we did talk about the standard American diet, the low fiber diet, processed meats, red meats. We talked about other things that I'll say that, so when I linked, I'm going to say associated or supposed associations. I would just tell everybody that, we have, not only do we have highly processed foods, but we have a fair amount of forever drugs in our environment. And actually you can find a lot of these forever drugs, these toxins, even in the urine of newborn babies. So we're ingesting a lot of things that have that, and I'm not talking about genetically altered, I'm just talking about pesticides, things like that in our environment. And I think we have to be a lot more aware of that. And I had one other thing I wanted to mention. A lot of people, there is a question about microplastics, and I think, that's something that we will, is yet to be seen, but there may be something there. Nilo, other things to offer in terms of environmental factors?
No, I think, those are all the things that we think about as well. People ask, should I be eating all organic foods? We don't know. I mean, I think I'll tell you personally in my home, when it comes to kind of the dirty dozen, I tend to do that with those, but I think it's very difficult to really be able to quantify what the risk is for these different things.
I will say that one thing I've found really interesting is how many foods and beverages that we can get in the United States that you can't get anywhere else. Meaning, we are a little bit more permissive in terms of what's in our foods. Half the stuff will not make it to shelves in Europe and in East Asia,
Yeah, especially the high fructose corn syrup based products, like if you go and get a soda, sodas aren't that great for us anyway. But if you go get a soda in many countries, they've got real sugar in them versus high fructose corn syrup, which has been shown in many very important papers in animals, not in human beings, but showing like it really does cause colon tissue to proliferate and become cancer. So there are a couple of questions I just wanted to mention. There's a couple of questions in the chat that are specific to a person's specific situation. We can't really comment on that because, those are things that we would want to be really safe about and make sure that we were really assessing someone's whole scenario. So we're not ignoring you. It's just a matter of kind of what the safe thing to do is. But someone did ask about colon wall resection. I didn't know if you had some thoughts on that.
Yeah, I'm not 100% sure what the question is asking, but I will tell you, I'm going to tell you a variant of that answer, so I hope I answer the question. There are certain very early stage rectal cancers that do not involve lymph nodes, do not involve the entire thickness of the muscular wall, that can be kind of cored out like a disc. And then you look at the final pathology, and if the final pathology is favorable, you can actually like save the person chemo, radiation, and an operation. So I hope I answered that question. And I think we have time for one other, but actually I think we're going to remind the audience to, as you see this last slide, please fill out the survey. And you can always email with any additional questions. And it's been a pleasure imparting this information to you. And actually, it's been nice to have this conversation with Nilo.
Thanks for inviting me. And I hope you all have a good rest of the evening. Bye-bye.
Thank you.
This will conclude this evening's webinar. We apologize if we were not able to answer all questions. If you would still like to have your question answered, please feel free to email hopkinsseminar@jhmi.edu. We would like to thank Drs. Migaly and Azad for presenting, and thank you everyone for joining us today. A recording will be emailed to everyone within the next few days. If you are interested in scheduling an appointment, please call one of the numbers on your screen. Thank you.